of your reproductive. Let's go back. We're going to talk about a little physiology of the urinary bladder. Okay. So what's a receptor do we have on the urinary bladder wall? You could start typing. The type of receptor in the urinary bladder wall in the bladder. Shouldn't take this long, folks. In the wall, there is two, but we focus mainly on M3. Okay. And this is called sphincter of the urinary bladder. What type of receptor do we have on the sphincter? What type of receptor? Gross, remember, how do you expect me to teach the pathology? That's alpha 1. Okay. Alpha 1 is on the sphincter, M3 is on the wall. Now, the normal way how it works, the bladder is there, and these white, the blue color, these are perineal muscles. These are perineal muscles, or another name for it is called pelvic floor muscles. Okay. The pelvic floor muscles or perineal muscles give structural support to the sphincter. So in another word, imagine if my apple pen is a sphincter, the perineal muscle is the one that giving the structural support to hold it. Is everybody clear, folks? Okay, it's important. So that muscle is there. And then you have the wall, which is the detrusor muscle with M3. Okay. Now, the normal physiology, when the bladder is full, right? So let's talk about it. So at residual volume, residual mean at empty, you always have some urine in there, okay? So let's say when that comes up to 150 ml, this is different person to person, okay? It's about their size, height, and tall and everything. But in a standardly, let's say if you have 150 ml in the urine, you will feel the first sense. The first sensation is that, okay, I need to go to the bathroom, but I'm not in a rush. When I get a chance, I will go. Is everybody clear, folks? That's your first feeling. When this 150 becomes approximately, let's say 200, for example, it could be 200, 250, you are going to get the second signal. This is where you need to go to the bathroom right away. We cannot wait anymore. Is that clear, folks? I mean, technically, that's how you feel always, right? We get the sensation, but I'm not in a rush. I could go when I get a chance. But then you get the second thing. Whenever you get the second signal, there is no waiting. You wanted to run. Is everybody clear, folks? That's the second signal, okay? Now, that signal is called maturation reflex, okay? The feeling, it's called maturation reflex, how you feel it and you get the sensation. So those senses are taken to the brain by your nerves, folks, okay? By your nerves, okay? By your nerves. So that's a normal physiology, folks. Is everybody clear? Now, there are two types of problem you could get in the urinary bladder. One, you have a hard time urinating, which means you are not able to urinate. We call urinary retention. Okay, urinary retention, that's one pathology. Okay, the second problem is you are not able to stop the urination, so you're kind of losing it. You are not able to control, kind of leaking. we call urinary incontinence. Okay, so urinary retention, urinary incontinence. These are the two possible pathology you could get it from urinary bladder. Is everybody clear, folks? Okay, now retention is always due to a side effect of a medication. 90% of the time it's caused by something we did, medical issues or something, folks. Okay, a good example I can tell is a pain medication, opioids, right? Pain medication causes urinary retention because pain medication causes spasm of the sphincter. When they cause spasm of the urinary bladder sphincter, we cannot urinate, folks. Okay, so that's the one. So because most of the urinary retentions are caused by medications, they don't ask too much question on step one, okay? Because it's always medication induced. Is everybody clear, folks? So majority of the question comes to you guys is in urinary incontinence, because urinary incontinence is a pathology. Actually, it happens in our body, not with medications and stuff. So we are going to talk about urinary incontinence, okay? Now, so the normal urination, how it works, in order to urinate, we have to do two things, folks. The bladder wall has to contract. That means we're going to say M3 agonist. So your bladder wall can contract and the sphincter has to relax. So it should be alpha-1 antagonist. This is normal. When every time somebody urinate, these are the two things that's happening in the urinary bladder. We are contracting the wall, M3 agonist, and we have to stop the sphincter so they don't close it tight. So we do alpha-1 antagonist. Is everybody clear, folks?
We're relaxing the sphincter.
To relax the sphincter, that is correct. To relax the sphincter, we have to give alpha-1 antagonist. Okay. So that tells you if somebody has a urinary retention, I'm just mentioning here, folks. Okay. If somebody has a urinary retention problem, this is what you need to treat, because they are not able to urinate. So if you give M3 agonist and alpha-1 antagonist, they should be able to urinate. Is everybody clear, folks? So that's a treatment for this. Okay. Now, on the other hand, if a patient are continuously urinating, kind of leaking, they are not able to control, we have to do opposite. We have to do M3 antagonist, alpha-1 agonist. So this will close the sphincter and will relax the bladder wall, so you are not contracting anymore, so you would not leak continuously. Is everybody clear, folks? Okay. So I'm giving you the treatment before we even talk about the disease, so you could understand what's exactly happening. Are we clear with this, Mallory? Good? Okay. So that's the basics, folks. Now, there are different types of urinary incontinence. So we're going to talk about first one. Now, I'm going to erase all these things. Are you guys done copying? Yeah. The first incontinence we are going to talk about, it's called stress incontinence. Okay, we are going to talk about stress incontinence. Now, let's try to understand the pathology. Okay, now when we say stress incontinence, it's basically what happens is, let's say I will start with the scenario. This mother has given multiple vaginal birth. Okay, so when people give multiple vaginal birth, it causes stretch of these perineal muscles. The perineal muscles become more stretched because when the baby comes through the birth canal, those stretches the muscle, folks. Okay, so when multiple birth, you don't ask me how many births you have to give it. It's individual, folks. Okay. Some people with 2 births, they get this. Some people have given 10 births, didn't have a problem. Okay, so it's all individual basis. But the idea is when we give multiple vaginal deliveries, the muscle gets stretched. So imagine if my fingers are the muscle, if the muscle is stretched, The sphincter doesn't get structural support. Is that clear, folks? The sphincter doesn't get structural support. So at that time, if anybody can increase your intra-abdominal pressure, any activity we do that increases the intra-abdominal pressure will push the urine out. Does that make sense, folks? So now what are those activities that can increase the intra-abdominal pressure? Coughing, running, jogging, even laughing loud, anything, folks. You know what are the things that can increase your intra-abdominal pressure. Now, in a healthy people, if you cough, that increases the intra-abdominal pressure, but we don't leak, is because we have a good muscle support. Is everybody clear, folks? Here, the muscle is weak. That's why the minutes we increase the intra-abdominal pressure, we leak, folks. Is everybody clear? Now, this is the easiest of all of them because they give you enough information that to tell that they were increasing intra-abdominal pressure. Is everybody clear, folks? Now, let's go back here and see. Now, here, it's outlet incompetence, urethral hypermobility or intrinsic sphincter deficiency, leak with increased intra-abdominal pressure, like sneezing, lifting something heavy, object, coughing, running, jogging, anything, folks, okay? So the bottom line is increase in intra-abdominal pressure will make the urine come out. Is everybody clear, folks? So that's stress incontinence, okay? Now, when the patient comes to us, we could diagnose them on the spot. That's called positive bladder stress test, right? So we tell the patient to cough or do something in front of us to increase the intra-abdominal pressure, and we could see the leakage of urine. And so we diagnose right there, folks. Is everybody clear, folks? Now look at the causes. Obesity can cause, multiple pregnancy, vaginal deliveries, all these things. In male, prostate surgery, those can make it. Okay, folks? So those are the reasons or association with stress incontinence. Now, what is the pathology I said? Pelvic floor muscle weakness, isn't it, folks? Now, theoretically, the Kegel exercise, you guys heard that. That exercises tend to be helping to increase the strength of the pelvic muscle floor. So, if people do that, but the problem is it cannot be done in a quick or short period of time. Research have shown for people to do Kegel exercise to strengthen the pelvic muscle, it takes about 6 to 12 months. Okay, that's number one. Number two, nobody becomes successful by practicing Kegel exercise. So theoretically, it's possible, but practically, it doesn't work, folks. Okay, so that's one option. Next, the best option is surgery. There's a surgery called urethropexy. Okay, urethropexy. You don't have to know how it's done. All you need to know, it's a surgery. In that surgery, what they do, they go around the sphincter and they put a band and they tighten it. That's all it is, folks, okay? They add some band and then they tighten the sphincter. So they're pulling both pelvic muscle together. So that's that surgery, urethropexy, folks. Is everybody clear? So that's urethropexy. Now, there was an NBME question. Okay, this NBME is removed now. It's an old one, but still, it's a question. They gave a scenario of stress incontinence. They said that patient is planning to go for surgery. Of course, the surgery don't happen overnight. It takes a couple of months to plan and do it. They ask, what is the best next step? Or what is the quick solution for this patient? So, because, the question was saying, patient is so embarrassed to go in public because when she goes to public and cough or sneeze, she's leaking. And because of that, she doesn't want to go. But what is the best short-term treatment? Most of the students missed this question. The answer was prescribe adult's diaper. That was actually treatment because there's nothing else you could do. And you have to prescribe the adult's diaper. So this way, the person is safe to go out. Is that clear, folks? Did you know in the United States, they sell more adult's diaper per day than the kids' diaper? They sell more adult's diaper than the kids. Kids uses more diapers, we think, right? They use at least 10 a day, isn't it? Right? 10 minimum I'm talking about. People like lazy like me, I only change every 4 hours or 3 hours. But for the kids, but you are supposed to change every 2 hours, and then every time they go 2, right? So imagine if they are changing 10 to 12, they sell more adults diaper than that. And US has a biggest problem of urinary incontinence. That's why they brought this in step 1, because when I took steps, we were only tested about incontinence on step 2. We didn't even know what is urinary incontinence when I went to step 1 exam, because you learn incontinence in OB-GYN rotation. Does that make sense, folks? So because it's a huge problem in the United States, they are bringing in step 1 material now, folks, which is sucks, but you have no choice. Because when you don't see it in patients, it's very hard. They said they spend about $1 billion a year to treatment of urinary incontinence. So, every year they release the statistics, the last year, how much they spend the whole US for each diseases. It's pretty interesting to take a look. Urinary incontinence is one of the biggest problem here. Okay, so that's why they ask question. 100% you're going to get 1 or 2 question minimum on urinary incontinence. But so you have to know. So that is your stress incontinence. Is everybody clear, folks? So we know the pathology. We know exactly what happens. Now I'm going to move to the next one. Okay. Now, next one we're going to talk about urge incontinence. Okay. Urge incontinence also has another name, hypertonic bladder. Hypertonic bladder. Or hypertonic incontinence. Okay, you will see what happens here, folks. Now, what happens here, folks? These patients with the word of urge incontinence, listen carefully, okay? You know how we say it? Every time you want to go to the bathroom, you get 2 signals, first and second signal, isn't it, folks? These people are not getting the first signal. They are straight away getting the second signal, okay? So what happens is the muscles of detrusors started contracting randomly. Not necessarily your bladder is full. Is that clear, folks? Not necessarily they are full. They're quickly contracting randomly. When they contract, the urine is going to come out. Does that make sense, folks? So they feel the second signal is as of a signal. So basically like this, I'm sitting here, all of a sudden I have to run to the bathroom. Is that clear, folks? That's what the word comes, urge incontinence, urgency. Is everybody clear, folks? The pathology is, you could see here, detrusor overactivity. So there, nobody knows when your detrusor muscle is contracting. They are only supposed to contract when the bladder is full and after you're having your first signal and a second signal. But here, leak with urge to void immediately. Is everybody clear, folks? How do you think the question say? This is another easy buzzword. The patient feels the urge to go to the bathroom, but she never makes it on time. That word is there. She will never make it on time because she received the second signal too late. So by the time she makes it to the bathroom, she will leak. Is that clear, folks?
Dr. William, could you go over that one more time?
Which part?
The detrusor part.
Detrusor is hyperactivity. Detrusor muscle is working randomly. Simple. Okay. So when I use the word hyperactivity, it's contracting. Under no, when there's no need to contract, they're contracting. That's what the idea is. They are supposed to contract only when the bladder is full. Is that clear, folks? So that's the idea. Like, imagine if you guys are sitting there, all of a sudden you feel that you need to pee right away. You have to run. Does that make sense, folks? That's the idea here, folks, okay? Nobody knows when this contraction is coming. It just happened randomly, folks, okay? So that's the idea. You could see here, you see they are showing that's a detrusor overactivity muscle, and they are contracting, folks, okay? Now, the reason nobody knows, sometimes you could say some UTI is irritating the urinary bladder, so different things, but we don't have a specific thing that causes, folks, okay? So that's urge incontinence, okay? Now,
sorry,
yeah.
Dr. Are you saying that so the bladder doesn't have to be full, but they'll still leak? And
yeah, of course, bladder doesn't have to be full. Even if you have 50 ml, if the bladder contract, you will leak.
And it just skips the first signal, even though it's not full. Like it doesn't.
No, it doesn't give the first signal. You just get the second signal.
Thank you.
You are not getting in order to prepare.
I had another question. So, so when I was in OB/GYN rotation, we used to have one patient, but I forgot what exactly was it called. Like the patient would always have to go to the bathroom right away whenever she's close to the bathroom.
That's different.
That's not this.
That's a psychological problem. That has nothing to do with. There are people when they see the bathroom sign, they have to go to bathroom.
Like she couldn't control, and she would always leak right before
The problem is there. Yeah.
It's not counted as urinary incontinence.
No. See, urinary incontinence, if you think about it, they shouldn't see the bathroom. Without seeing the bathroom, they should feel that. Is that clear, folks? And there are a lot of people, especially elderly women, they're above 50. What happens is when they see the bathroom, they feel like they want to go it. And if they don't, they get uneasy. Okay. So those stuff that.
Like she used to say, like whenever she's close to her door, that's when the urgency comes, and then she can't control it. By the time she reaches to the bathroom, it leaks. That's what she used to say.
No, so if she see, if you tell me if she sees the bathroom sign and she need to go to the bathroom, that's not urgent incontinence, my point. But if she tells you that I get the sense and then I am not able to make it on time, that's urgent incontinence. So the history has to be very precise here.
Okay, so like the only problem with her is whenever she's close to the bathroom. That's it. That's all when it happens.
Okay, that's urgent. So that means you are telling that she runs to the bathroom without seeing the bathroom sign.
No. Whenever she's close to her home or the bathroom and she gets the urgency, then by the time she reaches to the bathroom, she would pee, like leak a little bit. That's what she said. So I'm just trying to say it's not urgent.
There could be a possibly urgent incontinence, but I feel like we need a proper history. History is not enough properly. It has to be very precise. Okay. So that's urge incontinence, folks. Okay. Now here, if you see, what did we say the problem here? Detrusor overactivity. Does that make sense, folks? So when the detrusor is overactive, we need to block this. So we could simply say antimuscarinic M3 blocker needs to be given to these patients, okay, because that's a muscle randomly contracting. Oxybutynin is a very good example for it, folks, okay. Oxybutynin can be given for that. So that's the idea. So this way, the muscle don't contract randomly. Is everybody clear? All right. So that's urge incontinence, folks. Any questions so far in stress and urge? No. We're going to move to the next one. Overflow incontinence. It's also called neurogenic. Neurogenic bladder. Have you heard that word, neurogenic bladder? That's that, folks. Okay, neurogenic bladder. Yeah. Now, when you go back here with the neurogenic bladder, or it's called overflow bladder incontinence, this is the pathology. They do not feel any sensation at all. They never feel that they need to go to the bathroom. It is a problem with the nerve. You see, the nerve is the one that carries the sensation, isn't it, folks? The nerve is the one that carries the signal to the brain when the bladder is full. But here, the nerve is not carrying it, folks. When the nerve cannot carry, so this patient's bladder might be so full, but they don't feel it. If they don't feel, would they go to the bathroom? No. So when do you think they would know? After they leak themselves, they will realize that they leaked. That's the only time they would know it, folks, okay? That's what the word comes, overflow. Because if you literally see, what's the physics behind here? Now, I need some space. The urinary sphincter here, it has some pressure, okay? It has a pressure. When the sphincter is tight, it has a pressure. I'm making up this number, folks, okay? Not necessarily true. I'm going to tell that's 100 millimeters of mercury. That's the pressure of the urinary sphincter. Is everybody clear, folks? what happened to the urinary bladder? If the bladder pressure becomes more than 100 millimeters of mercury, the urine will come out. Is everybody clear, folks? When the bladder pressure becomes more than the sphincter, that's a time the urine will come out. It's like how left ventricular will pump the blood when the left ventricle pressure is better than aortic pressure. Does that make sense, folks? So what happens in here? These people don't feel the sensation of urinating. So the urine keep accumulating in the bladder, and so much of urine, the pressure will go so higher than the sphincter, so they will leak it. So it's overflowing. Is everybody clear, folks? So that's an overflow. And the nerve is not carrying the signal. So you could blindly say a diabetic is a good example, because diabetic kills the nerves. The nerve don't function properly, okay? Now, if you see here, these people have incomplete emptying because detrusor underactivity. It doesn't. Leak with overfilling. That's the idea. The leak with overfilling, folks. These people do not. Make sure you write it next to it. No maturation reflex. They do not get any sensation. Maturation reflex is completely absent. Maturation reflex is completely absent. So they cannot feel it. If you think about it on a daily basis, we always feel it minimum once a day, isn't it, folks? These people will never feel the need to go to the bathroom. The only time they find out when they leak. That's the idea. Now, how do we diagnose? They will come to the hospital and we would ask them, do you feel the urge to go to the bathroom? They will say, no, I don't have to go. I'm good. But if we put a catheter, we will find so much urine inside the bladder. Is that clear, folks? Because they are not feeling the sensation, but the bladder is so full. That's why it says post-void residual on catheterization, folks. Is that clear? All right. Now, the reason, here you could see polyuria, diabetes. Okay. Now, some of your book might say multiple sclerosis. Do you guys have it here? If you're using an old or previous version, it says multiple sclerosis here. That's wrong. You want to move the multiple sclerosis to urge incontinence. If you don't move it, you will get the question wrong that we are about to do. Okay, careful. Multiple sclerosis is part of urge incontinence. Okay, it's part of urge incontinence. It's not overflow if you have it in your first aid. Now, what do we do to these people? You know, one of the best treatment they asked in the exam, timed voiding. What does that mean? Whether they feel or not, they have to have an alarm every 1 hour or half an hour. They have to go to the bathroom and try to urinate. This way, they will not fill up inside. Is that crystal clear, folks? So the timed voiding is the best step for overflow incontinence, because this way their pressure is not building up inside the bladder. Is everybody clear, folks? Okay, so that's that. So we have stress incontinence, urge incontinence, overflow incontinence. Is everybody clear with this? Okay, while you guys review, let me pull up some questions.